just take a moment and see if there are some visitors here that we should introduce. Do we have anybody who has, or are there any of you who are visiting Westerners who aren't really members of Westerners? Would you like to introduce yourselves?
I can. I'll go ahead. My name is Todd Berlin. I'm visiting from Chicago, Illinois. I'm Steve Berlin's son, and when he sent me the link and told me the topic, I knew I had to be here. So thank you for letting me join, and I'm pleased to meet everyone.
I adore your father. We adore your father and mother, and thank you so much for joining us.
Thank you for having me.
Any other
Ken,
visitors?
what about new members?
Well, I'm not a new member, but I am visiting. I'm Elaine Clark, and just fascinated by history, but a journalist by trade. This is a second meeting I've come to this year, and I'm really excited about the topic. So thank you all for having me.
Thanks, Elaine, and hopefully you won't have to be a visitor for very long. We'll find a way to make you a member soon.
Very kind, thank you.
With a little money, a lot happens.
Well, you know, there's nothing like journalism for having a lot of money burning a hole in your pocket.
I just finished reading a book that made me realize that the reason Utah became a state when it did was because of lots of payments to journalists. So there's a long tradition of that in Utah.
Well, I like to think that maybe our ethics have evolved somewhat since 19th century journalism was at its finest, although that is a particular topic of interest for me. So, you know, yeah. I am familiar with good yellow journalism, but.
Absolutely, and I didn't mean to suggest anything else.
It's all right, I take it in stride.
It is really interesting just how important support of newspapers in the United States was to the Utah becoming a state, and their support came at a cost to different people. So interesting. Anybody else who's visiting?
I see Pat Stewart.
Pat Stewart, where are you? Oh, there's two screens. I'm not seeing.
Pat, you need to hold down your space bar so that you're unmuted.
Okay. Is it unmuted?
So you can also go down on the menu down at the bottom, the ribbon. There's a mute, unmute over in the lower left hand corner. Steve Gallinson, where are you? Go ahead. I'm sorry, Pat, for interrupting. Please.
Oh, no, I'm all done. But Steve Berlin invited me and my husband again to listen to this. This is our second Zoom meeting, so thank you very much for the invitation.
Thank you. Who else is visiting?
Brent Harridge is my guest again. He's
Great.
been coming about every month.
That's great. Brent, it's great to have you here.
Yeah.
And Steve Gallinson, you're going to have to tell us where you are. You're going to have to unmute, but we see that you're on a lake somewhere.
He told us already he's on Strawberry Reservoir.
Oh, he's on there.
How's that sound? You got me?
We got you now. You're on Strawberry Reservoir?
I'm on Soldier Creek. I'm
Okay.
out here fishing.
Well, if
Good
you
thing
catch
fishing
something,
slow, I wouldn't be watching the meeting here.
if you catch something, will you show us?
Yeah, I will.
Okay, great. Thank you. So I started to do this, and now I want to finish just highlighting a few of the things that are in our newsletter this month. It is full of interesting things to do and more interesting things to read and watch. There's a reproduction of a memorial from Pioneer Utah women complaining to Congress for trying to take their vote away. There's a book review by Kurt Bench on a new biography of Wild Bill Hickok. There are, timely though published years ago, columns by Will Bagley and Hal Schindler. There are links to lots of online sources, reading lists. Spend a week with the newsletter and you'll come away fascinated, better informed, and happier, I think. I mean, Steve has just done a lovely job and needs to be complimented on that. And I see lots of faces I haven't seen for a month or two, and welcome all of you. Thank you. I think we almost have everyone's dues collected. There may be one or two left out. We'll let you know if we haven't gotten your payment yet. And now our Dr. Joe Hatch is going to introduce our distinguished speaker, Dr. DeVon Hale, who will speak on the 1918 Spanish flu pandemic and the 2019 COVID-19 pandemic. Thank you.
Well, it is my pleasure to introduce my friend and colleague, Dr. DeVon Hale. And there is an excellent bio that Steve, can you hear me?
Yes.
Yes.
Yes. Okay. There's an excellent bio that Steve Berlin sent out that tells you about him, but I want to just mention three things. Dr. Hale is an infectious disease specialist, and he's a travel medicine expert, and he's a tropical disease expert. Now, we all see and hear and read, and we're deluged by people who are talking about right now about the COVID-19 situation, and I'm not sure where they get their information, but there are a lot of opinions out there, and some are poles apart, and so it's a wonderful thing to have Dr. Hale come and talk to us. And I first met Dr. Hale with listening to one of the talks he gave to the Missionary Medical Advisory Committee of the Church of Jesus Christ of Latter-day Saints in the church office building. And from the first one that I attended, and I've been attending that for many years, a lot of different medical specialists attend that, and a lot of people who are maybe a lot of retired docs and other healthcare professionals come to that who work in the church office building. And the network that is interested in the health and well-being of the missionaries is broad, and it needs to be, because there's 79,000 of those personnel out around the world. When I was in medical school, I heard about some exotic and unique diseases, and I thought at the time, gee, I may never see anything like that, but I hear about it a lot through the programs such as I heard DeVon speak to a long time ago. And they told us about dengue fever, and I'm an ophthalmologist, and I thought, well, that doesn't mean too much maybe. And I was in Auckland, New Zealand, and the people out there, many of them thought, well, it's pretty mild, and you often don't know when you have it, and maybe it doesn't seem very important. But I've also known of a case that had infection by dengue fever involving the macula of the eye. You hear people say, I have macular degeneration. Well, if you have macular inflammation, that's no good too. And so these things are important. And so on the two subjects you've already heard, I look forward to hearing from Dr. Hale. We need more doctors like him, and when he speaks, I listen. Thank you.
Mm-hmm.
You on, DeVon, I think?
Yeah.
Carry on.
Can I interrupt 1 second? Did anybody mention about the passing of Melvin Smith?
I didn't know about the passing of Mel Smith. Steve,
The obituary was in the paper today.
I missed it.
Yeah, it's in Sunday as well. It's a
Big
very
Greg, I'll
nice
take it.
obit.
He was an interesting guy. He was a good guy.
Greg got, I hate to interrupt, but you know, he was a very significant member of our Utah Westerners. Greg knew him
Absolutely.
well, and he definitely is missed.
Thank you, Steve.
Yep.
Okay, are you ready for me to start? Hello? Can you hear me?
I think we can now all hear you go. You are ready to go.
Okay. So I thought it was interesting that you are interested in both the influenza in 1918 and COVID-19 in 2020. I think that I learned a lot about the influenza that I hadn't realized before in getting this ready. And I hope that we cover some things that would be of interest to you. I tried to look at them with regards to case mortality. If you look at the influenza H1N1 or the Spanish flu, it really hit the world hard. In the US, about 1 out of every 5 people got influenza that year. In the world, about 1 out of every 4. Now you have to remember that in 1918, the population of the United States was around 103 million. So it was a much smaller group. And 25 million then is a pretty big group of people that were infected. And then that eventually died. Now, they didn't have computers and things, so most of the things here on the Spanish flu are estimated. The mortality in the US was around 675,000. But in the world, it was somewhere between 4 million and 100 million. And you go to the history of places outside of the US, like India, for example, you would go into villages and the whole village would have died. And it was a serious problem. And interesting that the highest mortality rates in the US were ages 20 to 50, which is a little bit different than what we see with COVID-19. So if you compare that, right now, this is from yesterday, 6 million people have essentially been infected. Worldwide, 29 million. In Utah, 58,000. Our mortality is much less, and mortality is less in the world, but particularly in Utah. In Utah, we've had 436 deaths, and our mortality is highest in the group over age 50. So a little bit of comparison there. We aren't anywhere near as serious as the Spanish flu, but we're surely serious enough that there are people that are being hurt from this infection. If you look at both of these are RNA viruses. Now that may not mean too much to you, but most animals in the world, including viruses, have both DNA and RNA. So these two viruses have RNA. So they share that. One of the things they share then is with just one strand of DNA and of RNA and no DNA to stabilize it. These types of viruses change very rapidly. They have a poor proofreading of their RNA that lets them skip parts of their reproduction, and this causes high mutation rates. So we know about that. So we know about antigenic drift. Antigenic drift is when there's a small change that is bad enough that maybe we need to change our vaccines. And we particularly are aware of that with our influenza vaccines. Every year, we have to look at what is the new strain of influenza this year so that we can make a vaccine that would have a better chance of being effective. Then there's a more serious one. The antigenic shift then is a change that allows a whole new alteration to the spread of the disease. And that's what we've seen with both the influenza and the COVID. And the biggest difference in those viruses was the ability to spread rapidly from one person to another. And we're not sure that we know what in their RNA allowed them to do that, but it made them entirely different types of organisms than what we normally see with those organisms. Now, this is just a little cartoon type thing. This is the virus up here, the virus particle. It can be a free particle in the environment. These viruses are not able to replicate without being in a mammalian cell. So they have to be in your cells or my cells in order to reproduce. And that's their goal in life. So if they're up here in the environment, they're looking for a receptor site that they can tie into. And these are specific receptor sites. These then are the virus's active area where they use to tie into a receptor site. It takes them, by the time they attach onto to your cell or my cell, it takes them about 15 minutes before they can release these virus RNA particles into our cytoplasm of one of our cells. Once they do that, they take over the whole management of the cell. They then run the cell so that they can reproduce. And there's this little thing called a ribosome. It reads the RNA pattern and it reproduces it. And then more of these reproduce and more of them reproduce. By the time they get ready to be released back into the environment, they may have as a million reproductions of this strand of RNA that then can go out and infect another mammalian cell. You do see that they go in here in the endoplasmic reticulum. That's where they replace and put everything back in order so that they can make a nice virus particle. Then they leave the cell. By the time you get that many viruses leaving the cell, it destroys that cell, and that's part of what causes us to be sick. Is they go in. If you have 100,000 or 1 million of these, then their job is to go to another part of our body and inhabit it. So let's look at that. In the history of 1918, they'd had several fairly severe influenza vaccines in the late 1800s. But this one in 1918 was just absolutely different. And it started out in Kansas, of all places. Hard to understand why it would start out in Kansas. Most all of these start in the Asian countries, and China is a major one of those. But in this case, the first clinical infections, the first clinical infections outbroke in Kansas, and it was in the spring, and they had about 3 months. And it acted just like any of the other influenza episodes that we've had almost every year. And then in September, by September, this then had become, within a 2-week period, had gone from a fairly benign virus to one that was lethal. And it began mostly in the military, and it spread in the military for the first 4 to 6 weeks, started in Philadelphia. Interestingly enough, President Wilson then was anxious to end the First World War. And the Europeans said, hey, we're winning, let's back off now, let's just start negotiating. Wilson didn't want to do that. He wanted the war to end in a way that would never allow a country to go to war like that again. And so he sent troops to Europe, and he started using training new troops, and then he spread. The other thing he did is he took the people from Philadelphia and he spread them to a number of different places where troops were in training, and he spread the disease as fast as anything could be spread. The scientists at the time disagreed with all that. Sounds similar to us, isn't it? And so the president said, well, I'm in charge. Let's get more troops. Let's send them to Europe. So they did. And the second thing he did was when they started getting lots of people. Oh, the other thing he said, this isn't a serious influenza. The influenza used to call the grippe. And he said, this isn't serious. Let's get this war taken care of. And then the second thing he did is he went throughout the whole country and identified 50% of the top military physicians, and he put them in the military so that when this hit the regular population of the country, not only was it serious to them, but they didn't have as many trained people to take care of them. So rapid spread, and rapid spread then just overwhelmed the resources. The hospitals were completely overwhelmed. They put up tents, they went up to hotels, they went anywhere they could to try and find places for sick people. The mortuaries were overwhelmed, medical supplies and personnel just completely overwhelmed. The people would pay extra to doctors or nurses if they'd come to help take care of them, because there was no way that all the service could be given. They sent a train from Illinois or into Illinois and Georgia. The one into Georgia started out with a trainload of packed military people. By the time it got to Georgia, 25% of them were seriously ill. And then the same thing happened. The French said, if we're going to finish this off, we need 100,000 troops in Europe. And Wilson got them together and sent them, and they managed to spread the flu all over Europe. Most of the countries in Europe kind of hid the fact that they had a serious problem. The people in Spain didn't do that. They reported accurately, and so they got the honorarium of having been called the Spanish flu. These people then came back from Europe. They went from the soldiers and then spread to the general public. So what do we know a little bit about it? It was very contagious. It had a similar thing to what we have with COVID, in that it had the ability to be infectious for 1 to 2 days before any symptoms. That's a terrible thing, because then we have people spreading the organism who don't even know that they're sick until after they've started to spread it. That's one of the problems we have with COVID. And then the symptoms were mild to rapidly life-threatening. There were people that would get this symptomatically and they would be dead in 24 hours. When they did autopsies, they found that this was not just a nasal congestion respiratory problem. They found damage to almost every organ system in the body. Muscles, lungs, liver, heart, kidneys, brain, adrenal glands. They had what we call now is a cytokine storm, where you get such a huge overdose that your body hyperacts and is actually then more dangerous than it is helpful. So they had all of those things that are very similar to what we've already had. I've already told you 15 minutes to inhabit host cells, 10 hours to complete a reproduction and destroy the host cell and release thousands to sometimes millions of new viruses that inhabit more host cells. These cells then are going to try and find a place where they can attach to a new cell and destroy and use it for their reproduction and destroy it. We've already talked a little bit about proofreading of the RNA, high mutation rates, and the most common death in the influenza was with pneumonia. Now, this was particularly bad because we didn't even know what a virus was. A virus had never been discovered, nor did we know anything about viruses causing disease. The scientists tried every way they could to try and identify what this was. And they went from miasma, if you know what miasma means, that's what people believed in before we developed a knowledge of bacteria and viruses. It's supposed to come from the bad vapors off the earth. So there was a whole group of people, they said, this is just the bad vapors from the earth causing this disease. They knew that it was a filtrated agent. So they knew something about bacteria, not very much. They knew a little bit about parasites. They had no concept of a infectious agent that was so small that it was a virus. So when they did cultures and when they did autopsies, they called it, they found a bacteria they called Bacillus influenza. They thought at one time it was the plague. They thought it was diphtheria or tetanus toxoid, or rabies toxin or typhoid. And it wasn't until 1932 that influenza virus was identified as the cause of this disease. So think of that. They had no concept of what this was, nor what to do with it. So they did a number of things, some of which were things we do. So they did home care, they did distancing, they did isolation, other than President Wilson, who put everybody together. They decontaminated infected areas. They used masks. Their masks were gauze materials. Have you ever seen a mask with gauze? They have so many holes in it. It is nothing like even the ones that we have. They did encourage hand washing. They tried all kinds of other sides. They tried putting germinal solutions up to their nose and in their mouth. They use mouthwash, iodine, glycerin, menthol, Vaseline. They said you can't spit anything or you're going to spread this. None of that worked. They did a closed gathering of people to prevent the spread. They did some vaccine trials, but they never used a virus to do that. They used pneumococcus, which is a bacteria, or some other things that if they hadn't made the vaccines, wouldn't have worked because it wasn't even targeted to the virus. They said, choose your food well, wash your hands, breathe through your nose, avoid tight clothes. There were a couple of interesting stories about towns, particularly over the U.S., but particularly in Utah and Idaho, where they just quarantined the whole town. If this was southern Idaho town or southern Utah town, if anybody came down the road, someone would meet them and take them through the town and tell them to get off on the other side. And some towns were then able to avoid the spread of this disease in their own area. So treatment, nothing worked. The hospital care by physician or nurses made no difference in the percent of survival. They did all kinds of things to try and treat this. They did bloodletting. They purged, so they had nausea and vomiting and diarrhea. They gave them typhoid vaccine, diphtheria antitoxin, codeine, digitalis. I don't know why they give strychnine they used, epinephrine, hydrogen peroxide mouthwash, nasal spray, warm milk enemas. Now there's a good one. IV mercury, and then rest, fresh air, and some caffeine. Their vaccines were not effective, not targeted. They did use oxygen. Oxygen may have helped some. They did this one study. They did one single study where they took serum from patients who had recovered and gave it to those who were sick. And their death rate went without treatment was 16%. And if they gave them this infusion, their survival was around 50%, or the death rate was around 50%. That sounded like a good idea, and that's what we're doing somewhat now, but it was never, they didn't have the facilities nor the ability to even do it clinically. They did it as a single study, and that's it. So that's kind of influenza in a real fast report. How did it end? So when it first spread, it was so lethal and so fast that it saturated the community very, very quickly and resulted in fewer persons then who were susceptible to infection. So what are we talking about? We're talking about herd immunity here. And so there were, if 1 out of 5 Americans got this, eventually you'd have around 20% or 30%, not high enough to really be good herd immunity, but maybe enough to make some difference. Let's see, over a number of months, this virus then gradually became less severe. And when it became less virulent, then more people were living, and they didn't spread it as easy. And eventually by 1919, it disappeared. Now, since then, we've had a couple of epidemics. In 1958 and 69, we had epidemics. I got influenza in 69. I remember that well. I would hate for anybody to have influenza. And then in 1976, we had a few pigs in the Midwest who got H1N1. We thought it was the same one as the one in 1918. And the government then provided vaccines for everyone. And that turned out not to even be a problem. But it did show that there were a number of side effects. When you immunize everybody in the country, there are some side effects from even a fairly benign vaccine like you get for influenza. All right, so let's go to coronavirus a little bit. This is the CDC's picture of coronavirus. It has these fantastic areas that are used to attach to our human cells.
No.
So COVID-19, just terminology-wise, is the disease. SARS-CoV-2 is the virus that causes the disease. There was a previous SARS outbreak in 2002 from a coronavirus. So it calls SARS-CoV-1, and SARS-CoV-2 then is our own little virus. There's another coronavirus in the Middle East that we get from camels. When we talk about infectivity, it's the ability to spread. Obviously, this organism spreads. Pathogenicity is variable. Some people are asymptomatic, others are severely ill. The virulence is the ability to cause harmful disease. And then immunogenicity is our ability to make antibodies to fight this. So interesting, this is not anything really exciting, except that the common ancestor of coronaviruses may have been present as long as 55 million years ago. But recently, only 8,000 years ago, it began to be more effective in attacking humans. It was divided into 4 different groups, the alpha, beta, and the delta gamma. Eventually, in 2400, between 2400 and 3300, it became more severe and more able to cause disease, and then we've had that problem since. So here's the DNA, just in the little thing here. The coronavirus is this one here that we're dealing with. This is the coronavirus from the 2002. You look at these, and they're really almost identical till you get out to this little tiny area here. And the new coronavirus 2 is about the same. 78% of it is the same as the one we dealt with in 2002. Not a very complex organism. We've already talked about that. So let's just go back, however. So we want to know what this is. What is the receptor on our cells that allows this organism to attach and cause trouble? And we know that. So in 2002, the SARS-CoV, the area of attachment is by an ACE2 inhibitor. It's an angiotensin converting enzyme. That's the same one that we see in SARS-CoV-2. So the problem we have is angiotensin converting enzyme is in high-risk areas in the upper respiratory tract and the nasal tract. But if we look at the rest of the body, that receptor is present on almost all the cells that we have from different organs in the body. So that even though we spread it from respiratory, as soon as it has its reproduction in our body, then it spreads to other sites of the body that make it dangerous. So this is an interesting site. How are we doing time-wise? This is an interesting site. There are actually 7 coronaviruses that infect humans. These ones with the yellow organisms here are ones that we've known about since the 1950s. They cause acute colds. So about 30% of the upper respiratory infections that we get over in 2 or 3 days or 7 days is from coronaviruses. The more serious ones then are the SARS-CoV-1 and 2 and the MERS from the camels. We're not going to spend time on this, but this is just the other animals, the other mammals of the world that we are familiar with that coronaviruses inhabit. Let's talk about the benign coronavirus infections. They cause mild upper respiratory infections. They cause anywhere from 15 to 35% of our upper respiratory infections every year. They seem to go up and down in 3-year cycles. That makes us worry a little bit. It makes us worry that we develop an immunity, and maybe over 3 years, we decrease that immunity. And so we worry about that now with the virus that is very serious. Will our immunity to protect ourselves, either getting the vaccine or getting the disease, how long of duration will that be? If it's like these mild ones, it may not last that very long. Again, these 4, not very much of a problem. The most serious problem is in really young children. This one causes croup thing that scares moms and dads. These then are the others. This is MERS. This is SARS from 2002. This is COVID. And if you look at those, the case fatality is much higher with MERS, much higher with SARS. This slide was put together in April 2020. At that point, we were thinking there was a 62% mortality in our COVID, and now we don't believe that. Right now, it's anywhere from around 1% to 3%. And the symptoms are about the same for all of them: fever, cough, dyspnea, diarrhea, but not as much diarrhea with our virus than previous ones. Sore throats, use of ventilators, much more used in MERS and SARS. So these diseases will have more mortality and had more serious diseases where they used ventilators more than we do. So a way to prevent SARS. If you don't want to get SARS, you go in your bedroom and you shut the door and never come out. So the goal is to not go to a place where you'll be infected, or if you're going to be out where there's that risk, you take the steps that would protect you from inhaling this into your throat or nose and transmitting the organism to you. So we do the same thing they did with the influenza. So distancing. So home care by yourself is the best way, but you can't live very long that way. So then distancing is probably the next way that would be more effectively protect you. Going to places where they're gathering places, or actually closing some of those places, that helps. Strict isolation techniques in hospitals. Hospital caretakers. My daughter is a respiratory therapist at a hospital. She goes in and she does all the techniques that prevent her from getting this disease. So the masks, the eye care, the hand washing, those kind of things. And out of about 38 or 40 people, none of them have gotten this. So if you do really good care, you don't get this from other people. Now, just talk a little bit about SARS. SARS was in 2002 to 2004, started in China, came to the Americas and landed in Toronto. And we took care of that really easily. The reason we did that is the receptors for that SARS were down deep in our lungs. And so we didn't spread it as easy. There was viral, the other thing is, when you started having symptoms, that's when you became contagious. Now, that's not what's COVID-19, where you have 2 or 3 days of spread before you begin to have symptoms. It's more like the influenza. Rarely, if any, was asymptomatic disease, and there were only local outbreaks, so we had adequate supplies, and halfway through this, they had a mutation that deleted 2 sections of their RNA, and that decreased their valence, and it went away. So scared us, gave us a preliminary for what we have now. Why can't we do those things now? The difference is the receptors that we have for COVID-19 are up in our upper respiratory tract, where you're more likely to cough or get them on your hands and spread them to someone else, even before you have symptoms. And then some people that don't ever get any symptoms. Rapid spread, high infectivity, we're short of supplies, and we've had mutations that tell us what part of the world this comes from, but it hasn't made the virus less contagious, less severe. This just talks about this kind of the same thing, home isolation, distancing, airborne. The 6 weeks came because we felt like there was an airborne that allowed distancing beyond 6 feet to not be very serious. Frequent hand washing, avoiding contact with our, after we go out and shake hands with someone and rub our eyes, what a great way to spread it. And then finally, face coverings and face coverings have caused so much political problems that it's hard to know how effective they are. But we know in the places where they're used and they're used well, there's not as much spread as where they don't use them. Now, is it the face covering, or is it because in those communities, the face covering is done well along with the other things? I'm not sure, but it does help. Now, in Utah, we began out with an orange status and went to a yellow and a green. And one of the problems, so home quarantine, yeah, for orange, we were told that if we stay home and keep our homes free of this virus, we're going to be less likely to get it. When we went to yellow, then you could get symptoms or a post-test and not as serious to be home quarantined unless you're infected. And then you do it just as if you were in an orange. Spacing, yes, for everything. Hand washing, contact with eyes and nose, yes, for everything, including green, which is what, so most of Utah is in yellow or green. Face coverings when unable to distance, yes, all the way across. So one of the problems we have is, if you look at these things, one of the problems we've had is we've gone to orange, to yellow, to green, and the concept has been in many people's minds is that means I don't have to do these. I don't have to wear the mask anymore. I don't have to wash my hands. I don't have to space because we're a green state now. That is not correct. If everybody did this, we could move much quicker to out into a normal society. And the problem is people aren't doing this. And so now we're starting to see another bump. And that's happened in Europe. It's happened in Sweden, where people all of a sudden say, oh, we've gone from yellow to green. We don't need to do that anymore. But the main difference is the amount of exposure you have other people. So here we didn't do much exposure. Here we did more exposure. Here we did much more exposure. And this is closer to being normal than anything we have. But it's not normal in the way that this is spread. The illness, a lot of non-specific things. But the one that's most unique about this virus is the loss of taste or smell. A third to a half of people develop this. Almost all of them that returns eventually. But other than that, pretty normal things. So these things can be handled usually at home. Usually these are not severe enough. And if you isolate that person at home so it doesn't spread to the rest of his family, then that's a good way to go. The thing you have to do then is know when to go to the emergency room. So when you get people with trouble breathing or cyanosis or persistent pain or pressure in their heart area or confusion or trouble waking them up, those can't be handled at home. Those then need to be seen and given special training. Diagnostic testing, we have antigen tests. 30 different companies are doing that. They have negative tests and positive tests, and false negative tests when the levels are undetectable. Positive test means that depends on what you do. If it's an antigen, active disease. If it's RNA, then you can either have active disease or you can have leftover dead virus that are still in your body. So sometimes you get false positives, sometimes false negatives. Who should be tested? If you have signs or symptoms consistent with the disease, good idea to be tested. And the reason is to know what to do with you. If you are tested and you're positive, then the people in your house have to be more careful. You need to isolate yourself. You need to try and prevent this from going to other people. If you're individuals that are going to start playing basketball or football or working in a stockyard, those groups of people are high risk. Sometimes they should be tested. Let's go on. We've already covered that. So these are high risk underlying medical conditions. These are the people that are more likely to die. So age is probably the most important. But look where this virus will attack the kidney, the lungs, the solid organ programs, those that are overweight with a BMI of greater than 30, heart conditions. It can attack the muscle of the heart, sickle cell disease, type 2 diabetics are higher risk, and then children are a pretty low risk unless they have some underlying disease also. So medications. So there have been a number of medications that have been reported to be worthwhile. None of them are really effective. None of them are curative. Most of them are done mainly to handle side effects of the disease. So the remdesivir is probably somewhat worthwhile. In the studies that were done there, people that took it or were given it got out of the ICU 4 days faster. It seems to help. The mortality was a little bit less, but it costs $3,000 and it has to be given IV and it's done in the hospital. So maybe saved for the really sick people. Hydroxychloroquine, initially there were some studies that said, hey, this is the cure. And there were certainly testimonials of people who took this and all of a sudden they were well. When they tried to reproduce those, they have been unreproducible. And in fact, in one of the studies where they tried to reproduce this, they had a 27% increase in mortality. So the CDC has said it's not worth this. Convalescent IV immune globulin from people who have recovered, that's looked favorable. The studies aren't conclusive, but they're looking at that better. So the immune globulin then is most effective during the acute disease. So if you're going to use it during the first 7 days. After the virus is gone and you just have damaged organs, this is not going to help you. Anticoagulants, so that there are receptor cells in your blood vessels, and that's called serious blood clots. They've had diseases with strokes, with heart disease, with heavy bleeding. And when they when they looked at people that were already on anticoagulants, the survival rate was 70 versus 37 who were without anticoagulants. So that then looks like it might be useful. And then dexamethasone. Dexamethasone is an anti-inflammatory. It tries to improve danger to organ systems. So it's most helpful, not during the acute disease like the immune globulin, but in the repair once you're over the acute disease. And People on ventilators, 35% mortality, less mortality, and even people that were on oxygen still improved with that. Now the final thing is vaccines. Vaccines, we test them in animals to see if they have severe side effects. We test them in animals and some humans to try and look how effective they are in preventing. And then we put them in large groups, and there are a huge number of vaccine people now that are doing their 30,000 people that they need to say, yeah, this is safe and it works. And that's kind of where we are. They're live vaccines, they're infect. One of the great advantages of all these over 100 vaccines being made is that frequently it takes multiple vaccine trials before we find what works best. If we have 100 or more all working together, this is a speed up possibility. We may be able to speed up and find ones that are going to be least dangerous and most effective. So that's good, and there are all kinds of ways they're doing it. You can become a volunteer for those if you want. If you go on the internet, they'll assign you to one of these if you want to go through that. So that's it. What time is it?
It's 5:02.
Do you have questions or anything we can?
Yeah, anybody have questions?
I do. Can you hear me?
Yes.
I am just baffled by this whole thing about how people's constitutional rights are being taken away because they're asked to wear a mask. I never thought I'd see anything like it. What do you attribute that to, and what can be done about it, in your opinion?
Yeah, that's a serious question, and discussion with many of these people doesn't solve any problems. So that they, in general, are committed to the idea that this interferes with their rights as individuals. I found an article today from Florida that 4 people in Florida sued the state of Florida so that they wouldn't have to wear masks. And here's what the court said. It says, constitutional rights and the ideals of limited government do not allow citizens to wholly shirk their social obligation to their fellow Americans or to society as a whole. After all, we do not have a constitutional right to infect others. So that's a Florida court conclusion. That's stated about as well as anything I know. But people that believe that this infringes on their rights as citizens, I've not ever been able to discuss that in a way that they would understand how I felt.
Yeah, they're not too open to discussion.
I've often wondered if those people feel that their constitutional rights are violated when they have to wear clothes out in public.
Steve or Craig, could you bring our speaker into center screen, please?
Let's see, maybe I can do that.
Yeah, Dr. Hale, just stop sharing your screen.
Okay.
Thank you.
I have a question. Mike Corlogas here. The governor is often criticized for his handling of the state's pandemic here. And the paper tomorrow will have a story that says less than 50% think he's done a nice job. What is your opinion of the way the state has handled the virus?
We still have you front and center, Doctor.
Yeah, how do I do that?
You're still sharing. Now we're looking at your screen.
It's
Dr. Hale,
impressive.
Computer screen.
which looks great.
There,
There you go.
There you
Now we
go.
got Joe. There we go. Now you just need to join the video somehow.
Yeah.
There you go.
hey, bingo.
All right.
That's while it lasted.
Oh. Now,
Okay.
there you go.
So if you look at what's happened in our state, the governor has been semi-good. There are some things that he's done that are useful, and probably the best thing that's happened is the state health department. And the state health department has some very well-trained people, and they have given Utah a better chance of avoiding this than almost any state in the country, and certainly a better chance to live, to not die from this. So the governor has not been completely on board, but he has not expressly interfered with the recommendations from the state health department. So I think that that's better than many of the states in the country.
Yet I just traveled in Colorado, and you could not take a mask off in public anywhere.
Yes.
So I think compared to what happened in Colorado, our governor's response has been pretty lacking.
Yeah.
I heard one thing about a recent vaccine trial. It got stopped for about a week, and it's been announced that the reason the trial was stopped was a case of transverse myelitis. And then they announced that it was not vaccine related and they could restart the trial. Unless the transverse myelitis occurred in the placebo arm, how could you determine that transverse myelitis was not vaccine related? I could not understand that.
Yeah, the only way that you could come to that conclusion is the rarity with which that side effect is caused by other vaccines. So I looked that up, and then in between 1970 and 2008, they had 37 cases of transverse myelitis that seemed to be associated and followed shortly after other vaccines. So it's likely that vaccines can do this, but how often it does it is extremely rare. But I don't know how they could decide that this was not related to the vaccine.
If I could make a comment on the earlier question about why people don't believe they have to wear a mask. I've heard very little about this, but it's been decided by the Supreme Court. In a court case, Jacobson versus Massachusetts in 1905. It was a 7-2 opinion. Supreme Court Justice Harlan said, the Constitution does not import an absolute right in each person to be at all times and in all circumstances wholly freed from restraint. A community has the right to protect itself against an epidemic and may at times, under the pressure of great dangers, be subjected to such restraint to be enforced by reasonable regulations as the safety of the general public may demand. So it's been settled by the court, but that doesn't matter to the people that don't want to wear masks. They only agree with the court and the Constitution when it supports their point, and they totally ignore it otherwise.
Well, and the best example of that in the modern world is anti-smoking. I mean, that's purely public health. I mean, people don't want to not have to smoke in public buildings or public spaces, and that is clearly constitutional, and it's no more oppressive than wearing a mask.
Yeah.
Larry, what was that court case again?
It's called Jacobson versus Massachusetts, 1905, and it was in reference to a health issue like this.
Yep.
May I ask a question?
Of course. Please.
As is noted, that was 1905. So this sort of resistance to these sorts of measures is nothing new. Did you come across any information about how resistance to health measures in the 1918 pandemic? Were people resistant to masks or staying in or not doing public gatherings? Do you see that in the written record?
The only thing that I found that made that a concern was the President Wilson himself.
Yeah,
And
I would
President
agree
Wilson,
with that.
Yeah, President Wilson himself says the war's more important. We've got to get these soldiers out. He did foolish things with regards to a spreading viral respiratory disease.
Amazing parallel to what's happening today.
Yeah, it absolutely is a direct read from today's experience. And it's amazing when you look at the history of the 1918 influenza and how it moved and who moved it.
Mm-hmm.
And
Right.
you also can see an earlier example in the 19th century where this was very much the case. And it's leadership. It's how leadership chooses to play the influenza movement.
Mm-hmm.
It's astounding to me how repetitive we are in 2020 to 1918.
Well, let me build on that. You know, you're from a university and I'm from a university, and these people are the same age as those soldiers. Maybe we in the universities are at fault. Maybe we are helping it spread by bringing the students back and maybe sending them back. I wondered what your comment was on the age similarity of the vectors of infection. Because it was soldiers, right?
Yeah, right. They were
They're
soldiers.
that age where, you know, if they want to go to a party, they're gonna go to a party. And we've shown here at BYU that it doesn't matter if you drink or don't drink, it still spreads.
So it was mentioned that the mortality rate was much younger, right, in the 1918 pandemic. So
It was.
in that period, one, you were being forced to gather as soldiers, and your life was at much more risk. I think probably students at BYU probably have more of a choice to gather than somebody who's been conscripted, and also probably aren't seeing the cost of it, because the real problem, it really occurs for people who are older.
Dr. Hale, do you have any sense of what the COVID-19 would do if we had medical kind of capabilities that we had in 1918?
Oh, I think we'd be in exactly the same position. Anytime you're going to ignore the steps that it takes to prevent this, you're going to be in serious trouble. And I think we've been able to do a little better now, because we've done some things that are the correct way to do it. But I worry that we're now losing control.
Yeah.
That we've lost control, and it's not just the young people, but the young people tend to lead that and don't look at them upon that as serious. But once we lose control of the ways to prevent this, I think then we're in trouble. I think we could be in a normal economy if everybody would take this seriously.
Yeah,
I agree with you very much. I think that our leadership for Utah, our leadership is in multiple groups. And I think there's been a major failure ultimately at the top of that leadership for every group.
Yeah.
And there are a lot of good explanations why it happens, but I think it's happened. And I would agree with you, Doctor.
I'd like to make two observations, Dr. Hill. First, they did quarantine some of the mountain counties in Colorado when people were fleeing the cities or the Texas or whatever coming up. In fact, the Attorney General of Texas was suing Gunnison County for not letting Texans go to their second homes. And then second, I think that a 1905 case isn't going to apply a lot when people were changing the constitution of the Supreme Court or consistency of it, hoping to reverse things that were passed in the last 40, 50, 60 years. So,
Keith, some of us who come from Western Colorado have been doing that for 70 years against the Texans.
I agree. I had a T-shirt when I lived in Texas that basically said if God wanted Texans to ski, he would have made BS white.
Bullshit white.
Yes.
In Colorado,
Dr. Hale,
those
could
t-shirts
I ask
go
you-
around in the 80s.
Yes, white. Bullshit.
Dr. Hale, could I ask you one other thing? There's a recent report looking at cytokine storm in COVID, saying that there's no evidence that it occurs, but interestingly, bradykinin storm does occur. And there's also one report of marked improvement in outcomes in a small group of patients that were given bradykinin inhibitors. Have you seen any of that data, and what do you think of it if you have? You may not have seen it. It's new within the last 4 or 5 days.
I have not seen it, but I can understand it because the cytokine storm is not a specific diagnosis. It's a whole group of responses. And so to have one single one that is more important than the other would not surprise me. And if that's the case, then targeting that would be better than targeting the whole group of reflex responses.
One last comment. When people tell me they don't have to wear a mask, you know, it's terrible. I just say, oh, so next time you have surgery, are you going to let your doctor not wear a mask and not wear gloves?
Absolutely.
A couple of quick comments, if I may. The first thing is I'd like to really thank you for your participation this evening. I've learned more in the last hour and 15 minutes than I have in the last 4 months. Thank you for that. Second thing is there an explanation as to the numbers that are coming out of Utah that show a remarkably low number of fatalities per 1,000 cases? And if I'm reading the numbers right, we're like second or third to the lowest in the nation relative to fatalities per 1,000 cases. Is there a reason for that?
There is. I think there's a reason for it. I think we have better medical care.
I like that.
Yeah, that's a great.
I agree.
But in addition to that, I think that we've not run into as short supplies as some other places. Yeah. And I think we've been able to work within our system and provide respirators, although we used them the wrong way to begin with, and now we're doing better. And now I think that we have 4 or 5 things that we can actually do that make a difference, whereas right at the beginning we didn't. And so I think we have good personnel. I think we have people that are very interested. There are people both at IHC and at the university doing studies to see how we can do this better. So I think we're involved in that also, like other places. I think that's part of the reason.
Doctor, do you think our youth average helps us?
It does from the standpoint of severe disease. So even though young people can get severe disease and die, the chance of that is much less. And so our lower age group in our population probably makes some difference too. It increases our risk, however, because those are people that aren't as compliant as maybe you and I would be.
Is there
Hey,
any
can I ask
truth to
Susan
the
a question?
statement that 3 ounces of Canadian whiskey every night will help you endure through the coronavirus?
No, but we could set up a study to look at that.
I've already started that study. I haven't had coronavirus yet.
I'm sorry, Mark. I'm sorry, Mark, but the mounted police won't help you.
So can I ask
Hey,
Susan a
I have
question?
a question. Okay, go ahead. I'll be
Susan,
after you.
since they've decided at BYU, it doesn't matter whether you drink or not. What are they advising students to do? Drink or not drink?
Well, of course, we think you shouldn't drink, but it doesn't seem to have lowered our caseloads. I
Oh.
mean, the idea was that if they just shut all the bars in these college towns, it'll go away. Well, you don't need liquor to spread it. That's what I'm saying.
Well,
Yeah. So my
just trying to get a
daughter is
reading on
freshman
what's
at
going on
BYU.
down in Provo.
If I
Tell you
could
what's going on down in Provo.
if I could
Let me talk.
interject, there are 2 people I think that have been trying for a long time to get
Barbara,
to say something. Miss Brown and also Linda Thatcher has her hand up.
Thank you. Okay, thank you. My daughter, freshman at BYU, and so we live in the city, which has hotspots, and our whole family has managed to remain free. I sent her down to BYU, and 8 days later she COVID down there, and she was following the rule, just in groups and wearing a mask and so forth. But some of her friends, turns out, going to these parties that student at you, Haku, them every week, huge. All these
He's
kids
a student
went to these
anymore.
parties and it. that's what I found out at BYU. But better now. Think. But I have a question about history and about our future. And the thing I want to ask about Will was anti-masker like Trump? And we know that they've ignored it, the soldiers. Did he ask in public person, or was he against that? That's my first. And then my second question is, how long do you think it'll be before we get back to some kind of normal? We're just predicting there, but what's your take on the future?
Let me take the second question first. I think it's going to be a long time. I think just dealing with this virus is going to be more than a year, maybe 2 years. Even if we get good vaccines, I think that the distribution and production and actually making an effective program is going to be fairly difficult to do. So I think that's going to be a problem. And then the other problem is, if we can't get people to cooperate in a way that will stop the spread of this, that's going to prolong.
Yeah. So
now your first question, I didn't quite get there was some back.
You're breaking up, Barbara.
Yeah, could you go through your first question again? Oops. Barbara?
Barbara, you need to unmute yourself.
You have to buy drinks all the way around.
My question was Woodrow Wilson an anti-masker? He used to wear a mask in public and that, or I was just he's similar to the current president that way as well.
was Wilson resistant to wearing masks?
Oh no, Wilson wasn't resistant to wearing masks. He just wouldn't take the steps to cause group people of being together, particularly in the military. So he and his generals said, "We've got a war to fight. We're going to fight the war. We don't care about putting all these people on the train or sending 100,000 people to Europe." But at that point, masks were not a political problem. And so he didn't object to the other things that they were trying to do to prevent it, but he wanted to win the war, and he did it at the risk of a lot of people dying. Does that answer your question?
Yes, very much.
Hey, hate to do this. Let's do one or two more questions. We're running late, and I want to make sure people keep coming back. Mike, do you have a question?
No.
Okay, sorry. You're in the center stage there. The Dr. Hale, this has been extraordinarily interesting and informative and helpful, and I join with others in thanking you for the clarity and the information you provided, and thank you very much. It's so timely, and I'm glad we've got such a nice turnout this evening. There's one announcement I failed to make, which is to hype Brad Westwood's podcast. It's called Speak Your Piece. The most recent one is a two-part series with Everett Bassett, who you'll recall, those of you who were at Westerners the night that Everett spoke to Westerners. He's a prominent archaeologist who found the burial site of the victims of Mountain Meadows Massacre, and it's more that Brad has talked to him about with respect to the Mountain Meadows Massacre site and his archaeological studies there, and what's happened since we heard from him a few years ago. The next month, our speaker is going to be a woman named Liz Clappin, speaking about what's called the magic carpet train. After the end of World War II, the live servicemen all came home, but then there was a massive undertaking to bring home the remains of American servicemen, and it's a fascinating story that she'll come and talk to us about. So be sure to circle the evening of Tuesday, October 20th, which will be the next time we'll get together on Zoom. And one of these days, in who knows when, we'll get together in person. In the meantime, we're doing the best we can to try to get everybody together every month. And I appreciate everyone's support, and keep the faith. Keep history in your lives, and there's lots of resources to learn more and more and more.
Thank you, Doctor, very much for joining us tonight. We really appreciate you and your expertise and your absolute brilliance in helping us through this era and period of difficult times. And thanks, Ken.
Thank you. Thanks, Greg. Thanks, Dr. Hale.
Hey, Ken, I got a quick question.